Thanks very much, Cass, for the kind introduction. I'd like to thank the Asthma Foundation for inviting me to talk today. We're given a slightly difficult topic of trying to solve the problem of bronchiectasis. And I'm just going to talk you through some of the aspects that, but I won't give you the exact solution. I'll talk you through what's currently happening in bronchiectasis. There's a lot happening in the bronchiectasis world. It's quite an exciting period to be in at the present time. So I'm going to talk a little bit about what is bronchiectasis to start with, and then talk about the some of the data from of the burden of disease in New Zealand, which you've already seen a lot of this morning. And then I'm going to give you a snapshot of the clinical trials that have been done recently to give you an idea of what's going on there. Yeah, could I have the screen up on front? Thanks. I haven't got my bifocals on today. So René Laennec, as many of you know well, is the father of bronchiectasis. So he was a French physician, and he was instrumental in developing a lot of respiratory medicine. But he was famous for developing the stethoscope. And you can see from the picture there the old way that they used to listen to the chest, put the ear up to the chest. And so that was a major advance. But as part of the development of the stethoscope, he described a number of respiratory conditions, in particular clinical signs. And he was the first to describe the features of bronchiectasis. Unfortunately, he died of tuberculosis at a young age. So this is bronchiectasis. So bronchiectasis come from the Latin word bronchus and the Greek word ectasis. And I use that to explain that to patients, and they usually pick that up pretty quickly. So it's a distortion of the airways. It's an airway disease, not an alveolar disease, and it's generally considered to be permanent, although I think we've all seen cases where there have been reversal of the condition. So this is the pathology and the CT scan that you can see there. So the pathology slide on the left there shows varicose, like a varicose veins. We call that varicose bronchiectasis. And the CT scan shows dilated airways. So we've known for a long time that there are two major components in bronchiectasis. There's neutrophilic inflammation and there's infection. And this early study from 2001 showed that there's active inflammation going on irrespective of whether the airways are colonized by pathogenic bacteria. But if they're colonized by pathogenic bacteria, then that inflammation increases. So they build on each other. And so we have inflammation and we have infection, and that leaves us options for treating those components or both. And this is the vicious cycle of bronchiectasis, where you have some initial damage to the bronchi, for instance, adenovirus in childhood or whooping cough, maybe a severe pneumonia. Subsequently, that damaged airway then gets colonized by bacteria, and that creates more inflammation, and you get a vicious cycle which perpetuates the airway damage inflammation. So we've known for a long time that the etiology or cause of bronchiectasis is predominantly unknown. So the idiopathic group, which is the largest, but there is also a large group of post-infectious group cause, and that's about 30%. So this is a systematic review of all the studies pulling together the etiologies and the associations with bronchiectasis. And you can see that predominantly it's idiopathic and post-infectious, but there are a wide variety of conditions that are linked to bronchiectasis. So it's a very heterogeneous condition, and that is part of the reason why it's difficult to manage and treat and also do research in. It is linked to COPD, more severe COPD, and is also linked to asthma. Now, this is an important development, a study which showed that viral infections are important in bronchiectasis. So we generally consider bronchiectasis to be related to bacterial infection, but viruses are just as important as they are in COPD and asthma. So that patients will get initial viral infection, and that can lead to exacerbation. So in this study, which looked at nasopharyngeal swabs and sputum samples, you can see that the exacerbations, 49% of them had a virus that was detected. And the predominant ones were those listed there: coronavirus, rhinovirus, and influenza. And there's also in the stable group, there is virus was also detected, and it may be that that has a role in exacerbations as well. We don't really know how that affects it at the moment. So this is data that you've already seen. So this is from the Asthma Foundation report, which has been was published last year. It's an excellent report, gives excellent data on New Zealand respiratory conditions, and particularly updated information on bronchiectasis. So you can see that the prevalence is high, 158 per 100,000, for a condition that was previously considered an extremely rare orphan disease. It's not really that rare. And if you compare that with COPD at the bottom of the slide, we have 800 per 100,000 prevalence, which is high, but 158 per 100,000 isn't really that much lower. It's not an orphan disease anymore. And as has been pointed out earlier, the key points about disease here are that it's very high prevalence in the Pacific and Māori populations, and that's a consistent finding across all the data. Incidence is the new cases that were detected in 2015, and that's 11 cases per 100,000. Hospitalizations, similarly. So here, this is data from a Wellington group published in New Zealand Medical Journal in 2015, showing that there's 26 per 100,000 that are admitted to hospital. That's the annual rate. And as been mentioned earlier, there's a double peak. So a little peak in the pediatric group, then they tend to go through a period where there's a relatively low hospitalization rate, but then there's a large hospitalization rate, as you might expect for the elderly patients. And again, the hospitalization rates are much higher for Pacific and Māori populations. So 9-fold higher for Pacific and 4.9 higher for the Māori population. And this study also did an economic analysis and importantly showed that there's a large cost to these admissions. That's not counting burden in the community. This is hospital admissions. That's $5 million a year. What about hospital admissions and the link to deprivation? You've already seen data on this, and again, is consistent in bronchiectasis. We can see that as you go to areas of greater deprivation, there's much higher rates of hospital admission. And it's again consistent across the ethnic groups, as has been mentioned earlier. So regardless of whether you are in a Caucasian group, Māori Pacific, the worse area or most deprived area that you live in, the more likely you are to have hospital admission and disease from bronchiectasis. This is data that Braden Teao, a health economist, did with our group recently, and he looked at mortality across New Zealand over a 10-year period. And again, the message is very similar. The mortality rate has been increasing. It's very high, 8.3-fold higher in Pacific peoples, and 4.7-fold higher in the Māori population. And again, it's a consistent message about deprivation, socioeconomic standards. This is data from Europe trying to predict how do we find out which patients are more likely to do poorly, and this is predicting mortality. And you can see here that lung function, FEV1, is important. That has an odds ratio of 5 times increased risk if you have a low FEV1. So if your lung function is 50% or less, then you have a very high risk of having death from bronchiectasis. Age is important. The older you are, and 70 is a cut point here, but the greater your age, the more likely you are to do poorly with bronchiectasis. More recently, Pseudomonas has taken center stage. There's now pretty good data showing that Pseudomonas is very important in bronchiectasis. So if you have it colonizing your airways, that's a bad sign. So it's a predictor of poor outcome, and particularly poor readmissions and high mortality. And although there isn't hard evidence for the aggressive treatment of Pseudomonas, that guidelines are now moving to recommend eradication of Pseudomonas if you find it colonizing your airways. Patients who are more short of breath and more symptomatic also do poorly. So what can we do about bronchiectasis? I don't have all the answers here. I think probably the thing that will have the most impact was discussed in the previous session, which is going to be dealing with the issues of deprivation, socioeconomic factors, poverty, overcrowding. Those are going to potentially have a huge impact on this disease. And at my side, where I'm looking at individual patients, we're looking at individual therapies to try and improve the situation. So I think we need a lot more research, a lot more information. We're just going off the base about bronchiectasis. We're learning a lot. We're going through a period of accelerated growth in this, and I'll show you some data on that. But we've got a lot to learn about bronchiectasis and how to treat it. But I think at a wider population level, it's very important to deal with the socioeconomic factors. So at the moment, the current treatments that we have, the main treatments are still the same. So the pillars are physiotherapy, sputum clearance, getting rid of that mucus so it doesn't become affected or can allow the organisms to grow and then proliferate. And antibiotics, usually a short course of antibiotics, 2 weeks if you get a flare-up of your disease. And we're still looking for new treatments that will help further. And I'm going to go through a few clinical trials later. In order to prevent bronchiectasis, we want to prevent infections. So influenza vaccination is recommended. And pneumococcal vaccine, I think, is also a good idea. Now, this is just showing you what's happening in the world of bronchiectasis. So over the last 10 years, there's been a dramatic increase in the publication rates, particularly over the last 5 years. Although the numbers are still relatively small compared to COPD, asthma. But there's a lot of interest in bronchiectasis, and you can see that from the publication rates. Now, we've heard a lot about the problem, particularly in the Pacific population. And if we're going to do a study, we might want to think about studying the Pacific population specifically. And I hadn't known about the Pacific families cohort until about 18 months ago, when Alain Vandal, one of the statistical professors, mentioned that in AUT they have, in Auckland, they've been running this for 18 years. And it's a fantastic cohort of patients who were born in Mannitol Hospital in 2000. They've been followed regularly right up to this point with a variety of different measures. There's been no extensive respiratory look at these patients, but there's extensive data on birth weight, their smoking exposures, what the parents, the families, the housing, lots of data from childhood right through to the age of 18, which they're sitting now. So we've set up a project which is a collaboration between Starship, led by Cass Burns, and AUT. Dan Tolo is the lead in the cohort, and Mannitol Hospital. And we're going to look at this cohort in a respiratory, to assess their respiratory status, to see what's happening at 18 years of age. But I think the real power of this will be in 10 or 20 years' time when we see whether they develop bronchiectasis. Now, a lot of the growth and the enthusiasm and energy that's in bronchiectasis at the moment is driven from Europe by the Ibaraki Registry. So this is a really impressive research collaboration. It was formed in 2012. It's largely driven by James Chalmers, who wrote the article there. You can see a summary of the current state of that registry. But where they really made an impact was when they got funded by the European Respiratory Society, and with a substantial amount of money. So it's 50 million euros to develop this, as well as for cystic fibrosis. But with that money, they've done fantastic things, and it's just amazing what they're doing. So in 5 years, less than 5 years, they've entered 10,000 patients in a registry. They've published a number of studies detailing what happens to those patients over time. And you can see that there are publications. They've developed a bronchiectasis severity index, which allows prediction of readmissions and mortality based on many of those factors I mentioned. They've looked at etiology. They've looked at phenotypes, comorbidities in patients with bronchiectasis. And they've looked at Pseudomonas as well, and the importance of that. So a lot of the research that's coming out on bronchiectasis currently is coming out from Europe. and that's because they're very, very collaborative and including other parts of the world as well. They've also set up the World Bronchiectasis meetings, which I'll tell you at the end about the next one coming up, but I highly recommend those. And they've also, as part of the offshoot, they've supported the Australian and Indian bronchiectasis registries. And one of the advantages of the Ibaraki registry is that they have a really great IT platform. So other countries can access that platform and enter data into that platform and have access to their own data, but also can compare with other countries. So we're just in the process of setting up a New Zealand registry, which will be a collaboration, an arm of the Australian registry, which also has an infrastructure based around the Australian Lung Foundation. There's a core data set of data that will be entered for each patient, but each country can develop their own data sets and fields. So for instance, in New Zealand, we would want to look at ethnicity and deprivation and other factors. We're just at the stage of getting national ethics approval, and then we'd be hoping to talk to groups across the country to develop how we might roll out this network of centres for a registry. So if anyone's interested in that, if they can come and have a talk to me about that. So what about the management of patients that we can do now? So I think it's important to try and recognise and diagnose bronchiectasis early. I think we're doing that better, and I think that that is a significant explanation for why the rates of bronchiectasis appear to be going up. We're certainly much more aware of it. We're doing a lot of CT scans, which for a variety of different reasons, and that they pick up bronchiectasis incidentally. Many patients who have thought to have severe COPD or severe asthma will subsequently have picked up have bronchiectasis picked up. So we are definitely recognising and picking up early, but it's important to do that even more. Patients need to be educated, and certainly recommend that they should have a physiotherapist who's a specialist in that area to educate and help them with sputum clearance techniques. And as mentioned earlier, the current main treatment, which is a consensus recommendation, is that patients should get 2 weeks of a broad spectrum antibiotic for a flare-up. And that's just based on expert opinion. There's no clear data on the length of the antibiotic course. The ERS guideline, which has just been published a couple of months ago, recommends eradication of Pseudomonas if patients are colonized by Pseudomonas. And that's slightly difficult at this part of the world because we don't have access to nebulized antibiotics as they do, or not as readily as they do in Europe and US, but I think nebulized antibiotics will be an important part of that, and I'll talk about that shortly. And pulmonary rehabilitation is strongly recommended in the European guidelines as being with strong evidence. So we should be thinking about putting our patients into pulmonary rehabilitation programs, which will be beneficial to them. Okay, so this is a list of the treatments that are available for bronchiectasis and the Cochrane reviews of them. And you can see that there's really very little. We haven't made a lot of progress in terms of treatment. So prolonged antibiotics, macrolide antibiotics are useful for preventing flare-ups of bronchiectasis. Nebulized antibiotics, there's limited evidence, but there's quite a lot of interest in this area, and I'll talk about the studies. Physiotherapy, there's very little evidence for treatment, but it's widely regarded as important. But we do need more data on that. There's no evidence in inhaled steroids or inhaled bronchodilators. Mannitol I'll talk about as an osmotic agent that increases fluid into the airways. Hypertonic saline again. Influenza, no trials. Pneumococcal vaccine, there's some data extrapolated from other conditions, but not specifically in bronchiectasis. But it seems sensible to recommend influenza pneumococcal vaccine because they're very safe. The last one is nebulized DNAs, which is actually harmful to patients with bronchiectasis. And that's important because it's very effective in cystic fibrosis. And a number of the treatments that have been effective in cystic fibrosis, which is a genetic form of bronchiectasis, don't work in non-CF bronchiectasis. And that's one of the difficulties we have. So I'm going to just briefly go through some of the data, snapshots of these trials that have been done, and I'll give you an idea of some of the challenges that we have in developing treatments for our patients. So these are the large randomized controlled trials that have been undertaken for macrolide antibiotics. Macrolide antibiotics are a special category of antibiotics that have multiple anti-inflammatory effects, as well as being an antibiotic. The antibiotic is highly concentrated within tissue, and even though if you have low levels in the blood, you'll have very high concentrations in the tissue. So theoretically, it's a very good drug to use in bronchiectasis. So you'll notice that there are two trials in New Zealand. So the one we did was in adults, and Cass led the New Zealand-Australian collaboration here, and that was in children. And just a summary of those results, the macrolide antibiotics are highly effective in bronchiectasis, and that they reduce exacerbations by 40 to 60%. So quite a large effect in reducing exacerbations. Modest effects on lung function, but we know that FEV1 is not a good endpoint in bronchiectasis, regardless of how effective the trial is. It doesn't seem to be an endpoint that moves with improvement. Quality of life does improve. So, and this is measured by the St. George's Respiratory Questionnaire. The studies overall did show a benefit in improving quality of life as well. But there are concerns about antimicrobial resistance, and that question is difficult to answer. Antimicrobial resistance is certainly develops in a large proportion of these patients who get long-term macrolide antibiotics, and they might have these for 6 months, 12 months, sometimes many years. But we don't believe that at the moment there are risks to the individual patient, but there are risks to the wider community in terms of overall antibiotic resistance. Inhaled mannitol, initially thought to be, there's a lot of enthusiasm for this. This is a powder that is an osmotic agent that you inhale through the device, and it draws fluid into the airway, has improved ciliary function, a variety of other mechanisms. But the idea is that it improves the clearance of the mucus and secretions. And this is a very large study, treatment over 1 year, but unfortunately it was negative for its primary endpoint, which was exacerbation rates. It did improve the median time to the first exacerbation by 40 days and improved quality of life, but statistically in 2.4 units, but 4 units is considered to be clinically important. So overall, it's a partially positive study, but the main endpoint was negative. What about inhaled antibiotics? There's a lot of activity in the sphere. So inhaled gentamicin, there's one study, single center, 65 patients, single blind, which showed a lot of positive endpoints. So reduction in microbiology, improvement in quality of life, reduced exacerbations. But it is a small study, and it uses the intravenous solution that you give for patients, and you nebulize it. And it does come with some side effects of wheeze and airway problems. So it is widely used, but it's not well evidence-based at this point in time. Now, inhaled aztreonam was developed by a pharmaceutical company, and they designed 2 trials, BX1 and BX2, large clinical trials looking to see whether there's an effect in bronchiectasis. Now, this trial, aztreonam inhaled is effective in cystic fibrosis, so there's good rationale to try that in bronchiectasis, and I'll talk more about the results of that. Inhaled colistin is an antibiotic that's been around for a long time. It's an old antibiotic. It's been used particularly in the Europe and the UK, and there's a recent clinical trial looking at that, and I'll talk about the results of that. And then there's these 2 new preparations of ciprofloxacin, which is an antibiotic specifically against Pseudomonas. It's the only oral antibiotic that can use against this agent. But these are inhaled preparations that are new. So the Respire 1 looks at these powder spheres. They've developed this technology where they can create these spheres, small spheres of antibiotic, and they can be inhaled and get down deep into the airways, and where they could deposit their ciprofloxacin. And the idea of these inhaled antibiotics is that you give them very high concentrations, and therefore, theoretically, they should be more effective. The other preparation is a dual-release liposomal ciprofloxacin, which is a combination of the ciprofloxacin encased in a liposome, so it dissolves slowly in the airway, and they can inhale these down again deep, and then the antibiotic releases slowly over time. But they also add in a little bit of free ciprofloxacin, so they get a rapid spike of activity from the antibiotics, an early peak and then a slow release of the antibiotic to see whether that works. And then there are amikacin and tobramycin are in phase 1 and phase 2 development. We'll hear more about those in the future. So just to summarize the results of the inhaled antibiotic trials. So the inhaled aztreonam studies were both negative, very negative. So they didn't show any clinical benefit, but they did have more side effects. So that doesn't seem to work in non-CF bronchiectasis, even though it works in cystic fibrosis. Inhaled colistin was a single study, one study done in Europe, and that was negative for its primary outcome, which was time to the first exacerbation. But if you took the patients who actually adhered strictly to the protocol, that was significant for their endpoint. So it probably was an underpowered study. There's certainly a signal that it could be helpful, but the primary endpoint again was negative. Okay, what about the Respire dry powder ciprofloxacin? There's Respire 1 and Respire 2. So in order to get FDA approval, you have to do 2 studies, and you give that data to the FDA. The FDA take the original data, they reanalyze it themselves, and then they decide whether they think it's useful to pass FDA approval. So you do 2 studies, and these are 2 large studies. One, they gave the medication in 14 days and then have 14 days off, 14 days on, 14 days off, a 2-week cycle to see that if that was more effective. And the other was in 28 days on, 28 days off. So month on, month off to see whether that was beneficial. So the results have been discussed at conference but not published yet. But this just was a news flash that came out last week. And unfortunately, the FDA have taken all the data, analysed it, and felt that it wasn't going to pass the test. So only one of the 4 primary endpoints met the criteria for significance. And so they voted that down, which is unfortunate, but that's another medication that's unlikely to be licensed. What about liposomal ciprofloxacin, the ORBIT studies? So this has been fast-tracked through the FDA process of approval, so they think there's merit in reviewing those. However, it's not guaranteed that those will pass either, because ORBIT 3 was not found to be significant for their primary endpoint, but there was a trend to positivity, and ORBIT 4 was shown to be positive. So there are differences across those studies, and the pharmaceutical analysis of the 2 studies was not overall positive. So we'll have to wait and see. But there appear to be protocol differences between the 2 studies. There were macrolide, some of the patients were on macrolides, and that was unbalanced in those studies. There were some problems in some of the sites. So there are difficulties in doing these studies, but it just shows you that it's a difficult area to research. So there's mixed results from these inhaled antibiotic studies. So what about long-acting bronchodilators? If you bronchodilate the airways, will that help the patients? Will they be able to clear sputum more? Tiotropium is a long-acting anticholinergic agent. It relaxes the muscle of the airway, allows bronchodilation. And we did a study looking at adults who had airflow limitation and gave them either tiotropium or placebo. And we had a crossover study of 90 patients, and they had a month gap in between, so a 12-month study. Unfortunately, we didn't show any significant difference for the primary outcome either. So exacerbation rates were very similar. There was an improvement in FEV1. So we did open up the airways by 58 mils on average. But this didn't seem to be clinically important. So clinically important differences around 100 mils. And in our secondary endpoints, we didn't show improvements in quality of life or symptoms. So it looks like there is a small bronchodilation, but it doesn't seem to affect the major important outcomes for patients with this medication. Okay, so what about some newer things? What about on the inflammation side? Are there any new agents that could possibly damp down the inflammation and therefore lead to improvement in bronchiectasis? So the statins are well known for their anti-inflammatory effects. They have anti-inflammatory effects in a variety of different conditions, including cardiac disease. And this is a study using high-dose atorvastatin versus placebo. Again, a single center study, small study of 60 patients. This was a positive study, and it's a proof of concept study. So it did show an effect, but a larger trial will be required for this. So their primary endpoint was Leicester Cough Questionnaire, which is a well-recognized questionnaire, and the level of significance or a change that you require to be clinically important is 1.3. So they showed a clinically important change in cough, reduction in cough with atorvastatin, and they also showed that there were their markers of inflammation were affected. It was a reduction in the inflammatory markers. So it seems to have some effect there, and it certainly would be useful to do a larger study. But it is associated with significant adverse effects. And the main ones were actually headache and diarrhea rather than muscle problems. This is another exploratory study of the CXCR2 or IL-8 receptor. And it's an antagonist that's produced by AstraZeneca. It doesn't have a formal name apart from the numbers there, AZD5069. So IL-8 is a key cytokine in the bronchiectasis airway. It's a cytokine that has much higher levels than any other cytokine if you measure them. And it's what attracts the neutrophils into the airway. So the theory is that if you can reduce neutrophil migration into the airway, then you might reduce inflammation in the airway. So the IL-8 binds to, in the diagram, CXCR1 and CXCR2, but it's predominantly CXCR2 that's the one that it binds to. CXCR1 on the neutrophil activates the neutrophil to release its products, and it improves the adhesion of the neutrophil to be able to latch to epithelium and enter the airway. But the other action of the CXCR2 is to improve the migration of neutrophils into the airway. And what they showed was that there was a 69% reduction in the neutrophil sputum cell counts. So it's looking like a reasonably sized effect there. And it was only a small study over a very short period, so it wasn't particularly looking at clinical outcomes. So I wouldn't be too concerned about the effect on clinical outcomes at this point. But we'll hopefully see more about that in the future. So I just want to finish by mentioning the World Bronchiectasis conferences. There's been 2 so far, and the next one is in the States next year. They're excellent meetings to go to, very focused, as you might expect, on bronchiectasis. A lot of the latest research is presented there, particularly from the European group. And so the next one is in July next year, and I hope some of you can make it there. Thank you very much. Oh, sorry, I'll just summarize. So just in summary, as mentioned, bronchiectasis is a large burden, particularly in New Zealand, particularly the Māori and the Pacific populations. We're learning a lot about bronchiectasis at the moment, but we're just off the base, and we've still got much more to learn about it. And from that knowledge, hopefully we'll be able to develop more and better treatments from that. Macrolides, as mentioned, are effective for preventing flare-ups. There are potential treatments that are available, but there have been mixed results so far. So there's a lot of optimism and energy in the sphere at the moment, and as mentioned, it's driven from Europe, but they're encompassing the rest of the world. And we'll hopefully see new things come out from that. Thank you.